When we think of interventional, what do we imagine? Do you think of stents, catheters, needles? Well, you are correct. What is interventional radiology? Interventional radiology, or also known as image-guided therapy, is a specialized field within radiology which uses medical imaging techniques to guide doctors as they diagnose and treat certain problems with blood vessels and lymph vessels throughout the body. Interventional radiologists are physicians who specialize in minimally invasive, targeted treatment performed using imaging guidance. Looking back at the history of interventional radiology, in 1923, angiography was first successively used for the human body. In 1953, a Swedish doctor, Van Ivar Seldinger, pioneered the Seldinger technique, which laid down the foundation of interventional radiology. In 1963, Charles Tudor Dotter is considered as the father of interventional radiology, who first proposed the idea of interventional radiology. While in 1964, the first interventional procedure ever documented was a percutaneous transluminal angioplasty of the superficial femoral artery performed by Dr. Charles Dotter on an 82-year-old woman with symptomatic leg ischemia and gangrene who declined amputation. So there are several types of procedures in interventional radiology, and here are some of them. First is the angiography, which is a radiologic exam of the vascular structures within the body after the introduction of iodinated contrast media. Next is the angioplasty, thrombolysis, embolization, vascular stents, and biopsy are interventional therapeutic procedures that are conducted in and through vessels. Next is the foreign body removal. The doctor puts a catheter into blood vessel to remove a foreign body in the vessel. Then, catheters insertions. The doctor puts a catheter into a large vein to give chemotherapy, medicines, nutrition, or hemodialysis. He or she may also put in a catheter before bone marrow transplant. Lastly, the cancer treatment. The doctors give the cancer medicine directly to the tumor site. Interventional radiology has the basic concept of keyhole surgery with X-ray vision. Although in today's practice, the vision can also be provided by other modalities, for example, the ultrasound, MRI, and CT, but fluoroscopy is the mostly used in an interventional procedure. The use of fluoroscopically guided interventional procedures can be conveniently defined as the procedures comprising guided therapeutic and diagnostic interventions by percutaneous or other access, usually performed under local anesthesia and/or sedation, with fluoroscopic imaging used to localize the lesion or treatment site, monitor the procedure, and control and document the therapy. The use of fluoroscopically guided interventional procedures is increasing around the world. These minimally invasive procedures are used as an alternative to conventional surgery, resulting in reduced patient morbidity and mortality. Radiation doses to patients from fluoroscopically guided interventional procedures may be high enough to cause skin injuries and increased probability of developing cancer in future years. There is also a risk to staff members of deterministic effects such as cataract formation. Although many fluoroscopically guided interventional procedures are conducted in radiology departments, they are increasingly performed by non-radiologists in other areas of the hospital, such as the hybrid operating rooms. It is important to ensure that adequate radiation protection training and support services are provided to staff members involved in fluoroscopically guided interventional procedures in all areas of the hospital.
Here are the main points to consider from the International Commission on Radiological Protection. Interventional radiology techniques are being used by an increasing number of clinicians that adequately train in radiation safety or radiobiology. Patients are suffering radiation-induced skin injuries due to unnecessarily high radiation doses. Younger patients may face an increased risk of future cancer. Many interventionists are not aware of the potential for injury from procedures, their occurrence, or the simple methods for decreasing their incidence utilizing those control strategies. Many patients are not being counseled on the radiation risk, nor followed up for the onset of injury, when radiation doses from difficult procedures may lead to such injury. Interventionists are having their practice limited or suffering injury and are exposing their staff to high doses. Occupational doses can be reduced by reducing unnecessarily patient dose and by the correct procurement and use of equipment, including the use of shielding devices.
Safety and interventional techniques. Interventional radiology. Interventional radiology offers the medicine in all countries, no matter the stage of development. The opportunity to treat a greater range of pathologies in more patients at a lesser cost. Interventional techniques reduce the need for expensive operating suites and extended hospital and patient admissions. They also reduce most of the risks to the patient by the use of minimally invasive techniques and through lesser requirements for general anesthesia. Additionally, they may allow therapy of lesions not previously accessible, although with concomitantly greater risk. Reports of radiation-induced injuries to patients' skin have been increasing since the early 1990s, with severe cases causing permanent disability and chronic intractable pain. These injuries are often avoidable if interventionists are aware of the radiation doses delivered to the skin. So this is a photograph of the patient's back 21 months after a coronary angiography and 2 angioplasty procedures within a 3-day period. Assess the cumulative dose 15,000 to 20,000 milligray. The patient has consistently refused skin grafting after excision of necrotic tissue. There are also possible longer-term effects for surviving patients, mainly induction of cancers. Many patients are in their later years, and interventional techniques are undertaken to improve quality of life. Such patients will often not survive long enough to develop a radiation-induced cancer. However, a significant and decreasing proportion of patients are in middle or early adult life, and some are children. If cured of their primary disease, many will have lifespan sufficient to develop radiation-induced cancers in organs irradiated during interventional procedures. Children, particularly those with life-threatening disease in very early life, are at the greatest risk as a consequence of the substantial radiation doses they incur during investigations. These children may subsequently develop leukemia within a few years as a result of the irradiation of bone marrow, and breast cancer or thyroid cancer as a result of chest or neck irradiation. The International Commission on Radiological Protection considers that there is no dose below which there is zero risk, and therefore minimizing the risk by confining the irradiation field and constraining the dose is highly desirable.
Effect on staffs. Patients are not the only people at risk. Staff receive doses from scattered radiation, but may not be aware of this fact nor aware of the risk this represents. And that, before the late 1960s, attempt at interventional radiology had been curtailed, mainly because of the radiation hazards involved, primarily to those performing the fluoroscopy. In some countries, cumulative radiation doses to the hands, eye, and thyroid may restrict the number of procedures that interventionists can undertake, and there had been disturbing reports of radiation injuries to clinicians, including cataract. As you can see in the picture, cataract in the eye of an interventionist after repeated use of old X-ray system and improper working conditions related to high level of scattered radiation. Staff doses correlate with patient doses, in that higher patient doses result in an increased amount of scattered radiation in the interventional suite. Additionally, staff doses can be considerably increased if inappropriate X-ray equipment or inadequate personal protection is used. These doses can be received not only by interventionists but also by other staff necessarily present in the room.
Practical actions to control radiation dose to both patients and our dedicated staff. First and foremost, we can apply the cardinal principle of radiation protection, in which the time, distance, and shielding. And the golden rule is to keep beam on time to an absolute minimum. This applies not only to our patient but also ensures the safety of our staff. In considering patient sizes and dose rates, it is essential to remember that dose rates are greater and dose accumulates faster in larger patients, so adjustments are necessary to varying patient sizes. To minimize patient dose, we keep the tube current as low as possible while maximizing the tube potential or KBP to strike a balance between image quality and safety from radiation. Next is to maximize tube to patient distance. The further the X-ray tube from the patient, the lower the radiation exposure. It is a simple yet effective way to enhance safety. Then, minimize image intensifier to patient distance. Conversely, keeping the image intensifier as close to the patient as possible ensures optimal image quality while minimizing radiation exposure. We also avoid overusing geometric magnification, as it can increase radiation exposure. It's all about using it wisely when necessary for detailed imaging. In procedures involving small patients or when the intensifier cannot be close, consider removing the grid to reduce unnecessary radiation. And always collimate closely to the area of interest, because this precision minimizes unnecessary exposure to the surrounding tissues. In case a procedure unexpectedly prolongs, we explore options to reposition the patient or alter the X-ray field, avoiding continuous exposure to the same skin area. In variable dose rates during intervention, dose rates can vary during an interventional procedure. It's crucial to monitor factors like beam location, angle, and dose rates to assess potential radiation injuries accurately. Now, let's shift our focus to controlling dose to our dedicated staff. Staff members should wear protective aprons, use shielding, and regularly monitor their radiation doses to ensure their safety. And positioning for minimum dose. If the beam is horizontal, operators stand on the image intensifier side to reduce personal dose. If vertical, keep the tube under the patient. These practical actions form the foundation of our commitment to patient and staff safety. By implementing these measures, we create a safer environment for everyone involved in the radiology process.
It is recommended by the ICRP, or the International Commission on Radiological Protection, that first, all persons undertaking interventional procedures should be aware of the potential and the nature of radiation injuries to patient and staff. Second, all departments performing interventional procedures should know the output parameters of their interventional radiological equipment and the typical doses delivered to patient and staff. Third, all interventional procedures should include measurement and recording of appropriate equipment technical factors used in the procedure. Fourth, all interventionists should be aware of the methods to reduce dose to patient and staff. Fifth, all interventionists should receive appropriate training. Sixth, all departments should set up procedures to audit practice and to ascertain radiation-induced complications. Seventh, all departments should set up processes to identify patients previously irradiated. Eighth, all patients should be informed of the likelihood of radiation effects as part of informed consent. Ninth, all interventional equipment manufacturers should provide ergonomic radiation protection devices, dose reduction features, and appropriate indicators of delivered doses. 10th, procedures for appropriate patient follow-up should be established.
Frequently asked question. What are the requirements for making a fluoroscopy facility safe? The following requirements need to be met to ensure that a fluoroscopy facility is safe, or registration of the fluoroscopy unit with the authority that regulates such facilities, authorization of the facility by the appropriate national authority. Authorization is typically granted after consideration of room size and shielding, staff training, and establishment of a quality control system for radiation protection. Conformity of the fluoroscopy system to the International Electrotechnical Commission or the IEC standards or appropriate national standards. Acceptance testing of the fluoroscopic system by a qualified medical physicist, and not only acceptance of the vendor's reports. Periodic safety checks in accordance with the protocols established by the relevant professional body or relevant international organization. Monitoring of radiation doses to patients and staff, and ensuring their conformity with the accepted standards.
Which fluoroscopic procedures have the potential to impart high radiation doses to patients? Procedures such as endovascular aneurysm repair, renal angioplasty, iliac angioplasty, kidney stent placement, therapeutic endoscopic retrograde cholangiopancreatography, and bile duct stenting and drainage have the potential to impart to high radiation doses to patients, as much as procedures in interventional radiology and interventional cardiology with a possibility of skin dose exceeding 1 gray. Any fluoroscopic procedure, when prolonged, may impart high radiation dose. Many of these procedures might be conducted outside the radiology department. Without appropriate staff training and implementation of radiation protection measures, dose to patients and risk may be high. These procedures require a higher level of optimization. To conclude this report, a statement from the International Commission on Radiological Protection said that there is no dose below which there is zero risk, and therefore minimizing the risk by confining the irradiation field and constraining the dose is highly desirable. The interventionist plays a big role in reducing risk by being educated enough and imposing realistic information to the patients about the risk in an interventional procedure. So this was Group Interventional Radiology of BIS RT3B, ending with the quote, "You can put a needle or drain into anything. The question that should be asked and answered is not if it can be done, but if the advantages outweigh the potential risk." Thank you.